Hi, my name is Dawn Carson. I'm the Wound Ostomy Continence Specialist for Penn Presby Medical Center here in Philadelphia. We are really pleased to be talking to you today about how to properly offload patients to prevent pressure ulcers. And we're also going to tell you about our journey in the surgical ICU here at Presbyterian. We have a wonderful interdisciplinary team, and you will meet some of the members of our team. We also have a great leadership team. And I want to talk about some of the things that were important that the leadership team here at Presbyterian were willing to do. One of those things was to get rid of what I call defensive assumptions. So they made no assumptions that everything was being done properly here in the surgical ICU, but they were willing to really look in real time and see what was being done, and then talk about solutions. So one of the things that we did as a team was we observed staff. We talked to staff about whether they felt turning was being done. And this was recently done also in a Todd Brindle study, where they talked to ICU staff members, physicians and nurses, to talk about whether they felt that they were turning their patients. 90% of those staff members said that they felt that they turned patients without exception all the time, every 2 hours. When they looked at it in real time, they found that that was not the case, that it was really done in 50% of the cases. So that was some of what we found also, was that when we looked at it in real time and we observed patients, one of two things was happening. Either patients were not turned properly to offload their sacral area, and we'll talk more about what that exactly means, or they were not turned as frequently as we thought they were. So we talked to staff about that and talked about solutions. And we found that we were not doing as well as we thought, so we needed to talk about how to solve that. So let's back up a little bit and talk about what a pressure ulcer is. When I talk about this with nursing students, who are usually sophomores in college, I like to ask them a question. What is a heart attack? And they very proudly raise their hand and say, I know, it's ischemia, it's lack of blood flow, it's tissue death. And then I say to them, when you think about a pressure ulcer, which is very commonly in the sacral area, but not always, of course, I want you to think about it as a butt attack, so that you remember that we're talking about lack of perfusion. In the same way, when we have lack of perfusion and no nutrients going to that tissue, we have tissue death. Our staging system is simply the extent of that tissue death. So when we talk about offloading patients, what are we really trying to do? We're really trying to restore the blood flow to that area. So if we're not doing that and the patient is still against the bed and their tissue is trapped between their bone and the surface that they're laying on, be it pressure relieving or not, they can still get a pressure ulcer. And yes, one of the assumptions that we also had to deal with was that staff members feel, and nurses, physicians alike, that patients cannot get pressure ulcers if they're on a pressure relieving surface. And that simply is not true. Or that turning is not necessary if the patient is on a pressure relieving surface. Also not true. So they were some of the things that we had to talk about. We also had to talk about turning critically ill patients. Since we are, of course, in a surgical ICU, our patients are very, very sick. And we found that there was an assumption that many patients could not be turned because they were so critically ill. So we had to look at the literature and take a look at that and say, what patients could be turned, and could they in fact be turned safely? And we found that with very few exceptions, all patients can be turned. So we talked about how do we do that effectively to make the patient comfortable and also to protect their airway. So they were some of the things that we had to work out and develop a procedure for. We also found that there was a lack of communication between nurses and CNAs and physicians. We added pressure ulcers to our rounding tool so that we could all be talking about what was happening with the patient, what do we have in place, what else did we need to add. And we also found that there was no ownership for the process. In other words, no one really owned the process of turning. There could be the assumption that the nurse owns it, but then the nurse felt that maybe the CNA should own it. So really, it didn't really belong with anyone. And so that really left us with poor outcomes. My colleague Dave is going to talk more about what we did and how we solved these problems.
Hi, how you doing? My name is David Ford. I'm a certified nursing assistant in the surgical ICU at Penn Presbyterian Hospital in Philadelphia. And we're here today to talk to you a little bit about pressure ulcer prevention program that we started on our floor. This program came about. We want to get the nursing assistants more involved in the care on our floor, and they felt a little disconnect on our floor with the nurses and the whole staff. So we came up with this pressure ulcer prevention program. It's a turn-in program where the nursing assistants actually take ownership of this program. The whole process goes about like this. The nurses come in, they're at change of shift. They do the first turn with the outgoing nurse. They do a skin check. Then every 2 hours after that, we're responsible to make sure these patients are turned and properly offloaded, whether it be getting an RN to help you, my partner, another NA on the floor, or anybody on the team that's working on the floor at the time is more than willing to help. Initially, I thought that I was properly turning these patients, just as everyone here properly thinks they were turning these patients. We first started off with training from the employee prevention specialist, and we came up with a turn-in schedule. We devised this turn-in schedule to get these patients turned every 2 hours. What we do is we take a sign and we have an emblem, and every time the person is offloaded, we move that turn-in schedule to the time they were offloaded. So if they were offloaded at 12 noon, we'll move that emblem up to 12. And what we do is every month we change the color of these signs so the employees don't get sign fatigue. We'll change the emblem to whatever going on that month. This month it's Halloween, so we did a Halloween theme. We'll do clovers in March and so on. And this sign just lets everybody on the floor know that the last time that person was turned. So if we walk by the room and we see this clock is not turned, then we know that that person has to be offloaded that hour. And it's a team effort. It takes a team to make this successful. It's not only the CNAs, it's also the RNs, the intensivists, the surgeons, whoever's on the floor at the time. I'm able to look out the door and ask them to come in the room, and they'll help me properly offload these patients and get the pressure off them.
I am Alexandra Rella, physical therapist and employee injury prevention specialist at Penn Medicine for the University of Pennsylvania Health System. In order to properly turn and position a patient, first you need wedges and plenty of pillows. If turning the patient manually, you need to make sure you have enough staff available to move the patient safely, both for patient and staff safety. NIOSH, the National Institute of Occupational Safety and Health, and the ANA Safe Patient Handling National Standards support a 35-pound recommended weight limit when lifting, pushing, and pulling patients to avoid cumulative trauma and damage to the spine. When exceeding a 35-pound recommended weight limit, caregivers will experience cumulative trauma to their backs, which is often painless, but that will lead to disc herniations, protrusions, and degeneration, ultimately leading to functional disability. In addition to staff safety, safe patient handling program goals include improving quality care by improving patient comfort and dignity during transfers, decreasing falls, skin tears, and pressure ulcers. Tips for proper positioning. To properly position a patient, you need a wedge and pillows. Whenever possible, flex the patient's hip and knee to assist with the turn. When placing the wedge, place it just above the sacrum and position the trunk and both lower extremities in approximately 30 degrees of side lying. Supported with a pillow, avoid pressure on the opposite greater trochanter. Use as many pillows as necessary to support all the extremities to maintain the patient in 30 degrees of side lying. Choose a larger wedge for larger patients. Check to ensure the pressure is off the sacrum. When available, you will use the ceiling lift to turn the patient onto their side. Often we use the repositioning sling to turn the patient. You can drop the bottom two straps of the repositioning sling to keep the patient in side lying to expose the sacral area for a skin check. In addition to the repositioning sling, you can also opt to use a turning sling.
Hi, I'm Joe DiMartino, the nurse manager in the surgical ICU at Penn Presbyterian Medical Center. So in summation, in order to initiate a successful pressure ulcer prevention project, you must include all disciplines, including leadership and frontline staff. Ensure that you have all the right equipment and make sure you're continuously assessing the process in order to ensure project success. Good luck.